So while everyone continues to roll in, we'll go over some basic housekeeping tonight. Thank you all for joining. Welcome to this great parent webinar. We have a wonderful moderator and two great panelists that I'll pass us over to really shortly. But just in the meantime, this is being recorded. The link will be available both on the Northwell Health YouTube channel by Monday, as well as those who attended will get a link directly through email to share, view, and all of that. We also will have recordings available in other languages, in Spanish and in Mandarin, in about 2 weeks from now, so look out for those as well. Aside from the recording, we will have time tonight for live Q&A, so our panelists will be taking questions directly from you, so please don't be shy. We will be taking questions through the Q&A, not the chat. So please use the Q&A feature. Do not wait till the end. Please feel free to write your questions in throughout, and we will try our best to get to as many of them as possible. I'm going to pass it over to Dr. Vera Foyer, who will be our moderator for tonight.
Thank you so much, Michelle, and thanks everybody for joining tonight. My name is Vera Foyer, and I work at the Children's Hospital. And I am so excited to have here with me today two of my colleagues, because I think when it comes to our kids and when it comes to the vaccine, us as parents have a lot of questions, and I'm so happy to have them here to share their expertise on the topic of the pediatric COVID vaccine. So with me is Dr. David Fagan and Dr. Mundeep Kaint, and they're gonna start by talking a little bit about the vaccine, and then we'll have interactive session and a chance to ask questions. Dr. Fagan?
Hey, thank you, Dr. Foyer, and thank you everybody for taking the time out of your evening to be with us. We have a lot of ground to cover, a lot of new information to share with you. So I'm going to start by sharing my screen. And get started. Okay. Okay, so I think everybody can see my screen. I'm going to start with a sobering slide from the Kaiser Family Foundation that, and they are continuously monitoring and publishing new data on the public's opinion about vaccination, especially children. And right now it stands at 3 in 10, 33% of parents say they're not going to vaccinate their 5 to 11-year-olds. And, you know, Dr. Kaint and I are here to convince you that vaccination is the right way to go to keep your children safe and to help us end this pandemic. So this is data that I like to show each time we do one of these webinars, and this gets updated every single week by the Children's Hospital Association of America, as well as the American Academy of Pediatrics. And it's really a misnomer when people say that COVID doesn't affect children. So when we're talking about children, we'll just think 18 years of age and younger. So since the beginning of the pandemic, there have been over 6.5 million cases of COVID in children. That's significant. And when the pandemic started, the percent of children infected out of all the total cases was like 2%. And now children represent almost 17% of all COVID cases cumulatively in the United States. We're over at this point 39 million cases of COVID infection in the US. And most recently, the number of cases, or the percent of cases in children as a number of percent of the total cases, has been really increasing. And this data is from last Thursday. And in that prior week, of all the new cases in the country, children represented 24%, or a quarter of all the new cases. And, you know, if you think about it, that makes some sense, right? As more and more adults are immunized, the virus is looking to see who's not immunized and who can it infect. And up until last week, when we had the approval for the 5 to 11-year-olds, the only children that could get vaccinated were the 12 to 17-year-olds. And that's why we've been seeing this increased number of cases in children. Here's a nice slide that looks at really from the beginning of the pandemic, the number of cases of COVID in children week by week. And if you see where that big blue arrow is, we really peaked at the end of August, where in 1 week, we had 250,000 new cases of COVID infection. So again, trying to make the point that when people say, oh, COVID doesn't affect children, that is not true. And here I'm showing you the data. Again, in the United States, there's over 75 million children, and we've had 6.5 million cases of COVID. Really, these are staggering numbers. Here's an interesting slide showing you that, again, the percent of cases that in children as a percent of the total are rising, and where that arrow is, all of those states above that, starting with North Dakota and going all the way up, Arkansas, Vermont, South Carolina, more than 20% of the new cases from the past week were in children. Again, more adults are vaccinated. Who can the virus infect? This shows you very nicely how it breaks down in cases in children across the country as we look at the Midwest, the Northeast, the South, and the West. And by far, we in the Northeast, we are in the best shape of any place in the country at this point. The numbers speak for themselves. This slide will show you week by week, going back to the beginning of the pandemic up until November 4th, last Thursday. The dark blue bars are children's cases. The light blue bars are adult cases. And again, that most recent peak that we had, really, the upslope started in the beginning to mid-July and really reached its peak at the end of August, was the Delta variant. And now we're on a hopefully continued downslope with those cases. But again, if you go back to the beginning of the pandemic and look at where we are now, more and more cases are happening in children. Not trying to beat a dead horse, but really just trying to make the point any way you look at it. More and more children are getting infected. This is looking at hospitalizations in kids. So, you've probably heard people say, maybe you've said it yourself, or you've heard friends or colleagues say, well, okay, kids who get COVID, they don't get sick, but there are kids every single day getting hospitalized with COVID. And again, with the Delta variant in July and August into September, we had an uptick. Since the beginning of the pandemic, if we just look at that 5 to 11-year-old age group that we're talking about immunizing now, there were over 8,300 hospitalizations just in that age group. So again, COVID infections in kids are mild. Well, no, not always. If you're the parent of one of those 8,300 kids who had to go to the hospital because of this virus, it's not mild. And, driving the point a little further, children do die of COVID. This is looking at deaths in the pediatric age group. The gray bars are the really young kids, 0 to 4, and this is broken down by sex. And then the darker blue bars are in the older children, 5 to 18 years of age. And if we add all these bars up, according to the CDC, and that's where this data is from, we have had about 700 pediatric deaths from COVID. And at this point, we're looking at really a vaccine preventable disease. The same way a measles vaccine prevents measles, polio vaccine prevents polio. Right now, with the advent of the vaccines that we have, COVID-19 is a vaccine preventable disease. So 700 children died. If you're parents or family members of any one of those 700 children, this has not been a mild illness for you, your family. This shows you how effective the vaccines are. If we look at the red line at the bottom, those are cases per 100,000 people in fully vaccinated. Yes, we know that there are breakthrough cases. Nobody's going to say that there's not. Those cases are for the most part mild. But you look at that blue line, those are cases in the unvaccinated population, and that big upswing was the Delta variant starting in the summer, and really a much muted or blunted effect in vaccinated people. Same goes for hospitalization. Big upswing in unvaccinated people when the Delta variant hit, a very muted effect for fully vaccinated people. And these last two slides I should just add are data from adults 18 years of age and older. Let's come back a little more local, and how are we doing with vaccination in New York State? This is a bar graph that was put out by the state last Thursday in a webinar that the state did for healthcare providers, showing you the percent of population by age that are fully vaccinated, completely vaccinated. Our 12 to 15-year-olds who became eligible for the vaccine last spring, we're at 57%, right? In our seniors, we're doing really well at over 90%. So as we all know, unless we've been hiding under a rock for the last week, the FDA approved and then the CDC endorsed the Pfizer vaccine for use in the 5 to 11-year-old age group at a reduced dose of 10 micrograms. The adult dose is 30 micrograms. 2 doses 21 days apart under emergency use authorization. And so in New York State, we have 1.5 million children that fit into this age group, 5 to 11-year-olds, that are eligible now for this vaccine. And you've probably heard the term herd immunity. And what that means, plain and simple, is we need to get a certain percentage of the population immunized to achieve herd immunity, which means that the community transmission of the virus will then really be blunted and tampered down. And most experts will tell you that with this virus, we probably need close to 90% of the population immunized. Now, if 20% of the US population is under the age of 18, we're never going to reach herd immunity unless we get a significant percent of our children immunized. So what are the benefits of immunizing children? And Dr. Camp is going to talk about this in a lot more detail, so I don't want to steal her thunder, but in Pfizer's study, almost 91% vaccine efficacy against symptomatic COVID. And I mentioned before, there were over 8,300 hospitalizations in this age group since the pandemic started. But one thing that I don't want people to lose sight of, you got to remember, even if it's a mild infection in a child, that there is that potential for that child, and the data supports this. They can function as super spreaders, and this. So we've had families who haven't been able to see grandparents, or families that haven't been able to interact with other loved ones and relatives because of maybe an immunocompromised relative or someone whose immune system is not working. So this secondary transmission is really important, and that's going to be a big benefit of vaccinating this age group. Not to even mention the fact that we can get back to having children not wear masks in school and being able to fully participate in extracurricular activities, in sports, and not have to worry about quarantining and school shutting down. I'll just give you an example. In San Francisco, they're doing really well in that adolescent age group. There's over 90% of their 12 to 17-year-olds are immunized. They've had, I think in the whole city of San Francisco, from what I read, 7 cases of COVID in the school in that age group. Just to show you what vaccination. This slide I came across and I said, I have to put this in. So what we're looking at here are different vaccine preventable diseases. And we're looking at the second bar where it says time period. That's the time period immediately before the vaccine against this particular disease came into use, and the average number of deaths per year. So with hepatitis A, in that 5-year period from 1990 to 1995, they were averaging 3 deaths a year. the vaccine came into use in 1996. Let's go to varicella, the chickenpox. In the period from 1990 to 1994, on average, there were 16 deaths a year from chickenpox before the vaccine came into being in 1996. Go all the way to the right. In that 5 to 11-year-old population, the population that just got approved for vaccination last week, in the last calendar year, from October 2020 to this past October, 66 children in that age group died in the past year. So my point is, in 1 year, the number of deaths from COVID in the 5 to 11-year-old outnumbers all the deaths from all these other illnesses before those particular vaccines came onto the market. Children do die of COVID. So are there risks for children getting the vaccine, especially in the 5 to 11-year-old group? And the most common adverse event were similar to or milder than those in teens and adults. You can have pain, you can have swelling and redness at the injection site, fever, fatigue, headache. You can see for yourself the other potential side effects. But the studies show that the effects are much milder in this age group than in teens or in adults. Now, I'm sure many people are having questions about myocarditis and pericarditis because you've heard about that. The studies show a much lower rate in this age group than in the adolescents. And the most important thing that you need to remember is the risk of myocarditis and pericarditis from getting COVID infection is far, far greater than the risk of getting it from the vaccine. Those cases that occurred in people following vaccination were really very, very mild, self-limited, typically treated with non-steroidal anti-inflammatories like Motrin. The risk and the severity of myocarditis from a COVID infection is far, far greater. So when people say, I don't want the vaccine because of the risk of myocarditis, you're running a much greater risk and with the potential for a much more severe case of myocarditis if your teen or child got a COVID infection. Okay, so another question that comes up, and we're going to talk about this in more detail, but just suffice it to say that if your child has been infected with COVID before, they still should be immunized. And we'll talk about that more in more detail. And there's really no minimum time that you have to wait if you've been infected, as long as you have recovered and have met criteria to end isolation. And we don't recommend getting tested for antibody levels to determine whether it's time or not time to get vaccinated at all. I just want to finish with 2 quick slides. Very simple to find locations to get your children immunized in this age group. And also, if you're an adult and you still need to be immunized, or you're a teen, just go on to the Northwell Health Coronavirus Digital Resource Center. You basically pop in your zip code, and it's asking you if you want a booster shot or if you're talking about the 5 to 11-year-olds, and it will give you locations. Many chain pharmacies have the vaccine. Our COVID general pediatric practices will be starting to immunize children within the next week. We're just waiting on receipt of vaccine from New York State. And then if for some reason somebody's seeing this on YouTube and they don't live in the New York metro area, vaccines.gov, which is a government website, will help you find a location no matter where you are in the United States. Pop in your zip code, you select a search radius and which vaccine you want to receive. So that's it for my slides. I am going to turn it back to Dr. Kampf for her presentation, and then we will be happy to entertain your questions. Thank you for listening.
Thank you so much. think we're good. We can see your slides.
Okay, great. Thank you so much, Dr. Fagan. So I see a lot of questions popping up in the chat, and I'm going to do my best to try to answer some of them as we're talking. So my name is Mandeep Kant. I'm a pediatric infectious disease doctor at Cohen Children's. So that means I see children that are in the hospital who might be sick with an infection, including COVID and multi-inflammatory syndrome in children, and I'll be touching about that. And also I see patients in our outpatient clinic, and I also have a background in virology and public health and research. So we're going to just touch through these different topics, all the way from what exactly the virus is, what vaccines are, because I think a lot of our questions about vaccine, or mRNA vaccine, and how vaccines are developed is sort of a cause of hesitancy amongst parents. So we're going to try to address that. We'll talk about what we've sort of seen epidemiologically with SARS-CoV-2, or the virus that causes COVID. Talk about how policies have sort of unfolded in school and why. And I'll talk a little bit about this multi-inflammatory syndrome in children, which I think is sort of one of those diagnoses that a lot of parents don't know about and should be made aware of. Okay. So here are some fun facts about viruses. So you're constantly being exposed to viruses in the air you breathe and the things you touch. And we have antibodies in our bloodstream that are always really just trying to get these invaders out of us. And they mark them, and then the white blood cells that we have in our circulation kind of engulf them and destroy them. And so what we're doing is basically trying to explain that, we're always sort of exposed to some kind of infective particle, and we're basically doing this, thousands of times a minute. So really, what really makes one virus different or cause an infection? And so this slide really explains, and I'm sorry if it's a little sciencey, but I think it really is a nice description and picture of what happens when a virus sees a human cell. So the little orange with the red spikes, that's what we've all come to know as coronavirus, as a crown of spikes. And it basically uses, this is the human cell, this gray thing, and it uses this little receptor on the cell to enter your human cell. And then what the virus does, it's super smart. It doesn't do any work on its own. It actually uses your own machinery, your own mRNA, to start creating more copies of itself. And how it sort of gets out of the cell, it like uses this little bubble, right? And gets out of the cell, and then it basically uses the cell's machinery to make more of itself. And that's what causes a virus to start causing an infection and symptoms. And so the most important part here of the virus that we're going to talk about is the spike protein a little bit, because a lot of questions are coming up about antibodies and what those mean. And I'll try to touch on that a little bit more when we talk about vaccines. So vaccines comes actually from the Latin word vacca, meaning cow. And this was a picture of Edward Jenner, who was inoculating a little boy, James Phipps, with the first ever vaccine for cow pox, which we also know later on also known as smallpox too. And basically cowpox was found on the hands of the milkmaids that used to get milk from cows before, they would try to inoculate the cows. And what happens is that these milkmaids would often get sick and transmit. And so they basically took a little bit of that matter that was sitting in her sore on her hand and inoculated him in his skin. And then his body basically, instead of getting sick with the disease, it basically created a little local reaction, probably a scar where they inoculated him, but protected him from getting super sick. And this was back in 1796. So first of all, vaccines are not new. And so we see that so many of our children get vaccinated from the time that they're infants. And, if you count it up, it's actually a lot of vaccines. And if you think about it, it's actually, if you want to guess, maybe is it 8 to 10, 14 to 15, 17 to 20? It's actually in the middle. It's 14 to 15 vaccines. And they're actually covering these major illnesses. that we don't see circulating much anymore because we vaccinate. And we continue to vaccinate even though we don't see them anymore because we don't want outbreaks to occur. And we've seen locally here in New York what's happened when we don't have communities who vaccinate against certain illnesses, like for example, MMR, we have measles outbreaks. So by a year of age, a baby might be getting 20 to 23 shots to protect them from all of these illnesses that can have a lot of complications, can have hospitalizations, and can make you even die. So how do vaccines work? So the way they work is that you get this little antigen in here in the vaccine, which is a protein. And when it goes into your body, it activates this antigen presenting cell. So basically, there's a cell that's sitting there, bunches and bunches of cells that take this little protein and then show it to these other cells. And these are your helper cells, these T helper cells, and they activate your B cells, and your B cells kind of start making the antibodies. And so if they see this antigen, if you get sick or you get exposed to COVID, you already will have the antibody memory there, okay? You also have this other pathway of immunology, and this is why I want to make this very clear. This is not a simple, cause and effect sort of immune response. The immune response is like a big spider web, and all of these cells that are involved have different roles to play, and they're shooting out their own inflammatory cytokines and shooting out their own responses to the vaccine and to actual infection, okay? But the difference here is that when you're giving a vaccine, you're basically being very, very, very specific. You're telling the body that this is the very specific part of that antibody, of that virus that you want. And that's where the spike protein comes in. It's like the little part of the actual, of the virus. That's what your vaccine is made of. It's actually trying to trigger your spike protein response. And the way we are doing that is we're trying to tell your cells to make that mRNA and to make your body say, oh, I recognize it. I know what to do next time I see it. And so how do we establish something is safe? And I saw one comment asking, how do we know it's safe in children? So actually, for the study that Dr. Fagan pointed out about 5 to 11-year-olds, the very first thing they did was they took a small number of children, less than 50 children, and they did different doses, okay? And they showed that the best dose that they saw for the immune response that they were looking for was that 10 microgram dose, okay? Which is the dose that's now being given to everyone, all the kids. And then it actually showed, well, it also doesn't have any side effects, but it's still creating that immune response we want. And then we open up this to this trial or these vaccine studies to a larger population. And so we have a certain group of kids who don't get vaccine, they're called placebo. And then we have a certain group of kids who get vaccine. And what we're doing is we're looking at how that immune response works, but more importantly, how many of the kids who have not gotten vaccine get infected with COVID versus those who do get vaccine. And there was a significant difference. That's what the 90% effectiveness comes from, where they saw that 90% of the time that vaccine is going to protect that 5 to 11-year-old from getting sick or from COVID. Okay. And so when we take that small population, then we go out and we distribute vaccine in a large population. And this is where the questions about EUA come in, where the approval process comes in. So I'm going to use a different vaccine as an example. So before COVID, we saw a lot of kids in our travel clinic who needed yellow fever vaccine, but there was a certain component of the vaccine that was no longer available. And so the vaccine that is FDA approved in the United States for yellow fever was no longer available. So what the FDA did was administer or authorize an emergency use authorization for a vaccine that was not FDA approved for yellow fever, but is FDA approved in other countries or approved in other countries to use. And that was because there was nothing else available. Like there's no other vaccine available to protect people who needed to travel for yellow fever. And so an emergency use authorization is when the FDA finds that there's no other way for a population to get a biologic or vaccine or a drug that is not normally available. And when you have a new drug or a new vaccine or something that is not normally used in our country, you have to have this process. And it's a very stringent, rigorous process that happens. And that's why it takes a long time. It's not that, you know, you get data, like the next day it's approved, and then the day after that you can get vaccine to the whole population. We literally in the pediatric world have been waiting since that first person was vaccinated, an adult, and as I was vaccinated like 2 days after the first person, Sandra Lindsay, in December, like literally almost a year I've been waiting to get this data. So this is not a fast process. And so do we see high risk or serious health outcomes with mRNA vaccines? And, you know, there were 6.2 million people who received 11.8 million doses of mRNA vaccine. And there was not a significant event rates for these 23 outcomes that they look for, serious health outcomes. For the people who were vaccinated, 1 to 21 days compared to those who were out of that time range of 22 to 42 days. So really, there was no serious outcomes that they saw. And, you know, that's why we keep having this follow-up. And that's why we will always have follow-up when we have all these reporting agencies like Be Safe, VAERS, and all these other CDC-run programs that are making sure that we are still making sure our vaccines are safe. And that's how we reassure you that, yes, there's a lot of work being done to keep making sure that these vaccines are safe for our children. So back to the study that was done in children. So actually 4,500 kids from 6 months to 11-year-olds were actually involved from 90 clinical trial sites. And they looked at the safety, tolerability, and immunogenicity. And these 3 age groups were like 5 to 11, which have been approved. There's 2 to 5 and 6 months to 2 years. And we're still waiting for the 2 to 5 year and 6 months to 2 years data. And we're seeing that with this dose that they chose of the 10 micrograms, that there was children who were, and this is another important point, so we know if vaccine works if you had or you did not have evidence of prior COVID infection. So they checked to see if those kids had prior COVID infection, but they were enrolled irregardless of that, if they had evidence or not. So these were not all kids who were never infected. These are a mix of kids who were infected and were not infected, who were under the trial data that we have. And so there's really no better data than a double-blinded placebo-controlled trial, which is the gold standard for studies. And honestly, in children, it's very hard to come by. And for side effects that we were, worried about initially, okay, so do kids have really bad side effects? And in the initial trial results, there was vaccine safety trial results that showed 12 to 15-year-olds only had really these most reported side effects or pain or injection site, fatigue, and fever. And you saw the efficacy was amazing, 100%. That means that they had 0 cases of COVID in the 1,000 kids they gave vaccine to compared to the 1,000 kids they gave placebo to. And Dr. Fagan touched on the myocarditis issue that came out after the trial was done, because when we put out something in the population, we start seeing if there's a trend. And the only trend that was noted was that after vaccination, in the second dose, males had a higher slightly higher possibility of having a myocarditis. But that myocarditis is not the same myocarditis that COVID causes. COVID causes myocarditis that puts you in the ICU and can even cause multi-inflammatory syndrome in children, which I'll talk about, which puts you in the ICU. This myocarditis was very mild, very self-limited, had maybe some elevation of some blood tests, and mostly normal echo findings, meaning when you looked at the heart with a sonogram like you do a baby, it was normal. And so when you make the point that, yes, there are side effects from a vaccine, you have to look at what is the overall risk and benefit for not just that individual patient, but for the population. And the very self-limited myocarditis that was slightly higher in a certain gender and age group was far, far outweighed by the number of COVID infections that would be prevented by a vaccine. And so that's why the decision was made to continue to give the 12 to 15-year-olds Pfizer vaccine. And we're still encouraging everyone to get that age group vaccinated, because that is actually the higher risk age group for severe disease that ended up hospitalized. And I can attest to it because I saw it last year myself and been continuing to see it since COVID has started. And so, so now going back to this trial, how do you tell that the immune response is good? So they looked at something called neutralizing antibody. And the reason I'm explaining this, because when people are asking, well, if my kid has antibodies, why should I get the vaccine? Well, neutralizing antibodies are a test that's done in the laboratory. It is not the same as checking for spike antibodies, which is to, just the vaccine antigen itself or that's found in the when the vaccine is triggering that immune response, or nucleocapsid antibody, which is sort of the shell part of it, which indicates that you actually had natural immunity. Neutralizing antibody means that this is what actually worked to neutralize, to stop the antigen or stop that virus. And that's what shows us that this is an immune response that's an effective, meaning it actually works to stop the virus from replicating itself. And when you see that, the comparison group actually for the trial for the 5 to 11-year-olds was that adolescent group. So they wanted to make sure that, look, we had a really great, 100% effectiveness. We had really great antibody responses in that 12 to 17-year-old group, but it was at 30 micrograms. So can we do the same? Can we do just as well when we do 10 micrograms? And you know what? It was great. It worked out perfectly. They actually showed that it works even for the 10 microgram dose. And this begs the question again of, what do you do if you have a patient who's bordering on 11 to 12-year-old, and do you give the 10 microgram dose or the 30 microgram dose? And here in New York State and in general, because we know the immune system doesn't suddenly snap like this when you're on your 12th birthday, it doesn't suddenly change. If you've gotten your first dose at 10 micrograms prior to your 12th birthday, but your second dose is after your 12th birthday, you can still be getting the 10 microgram dose, and that will be considered an actual dose that is considered to be a dose that is just as effective and just as immunogenic, as we call it, as a 30 microgram dose in that age group. So if a school or someone in the future is going to require, hey, documentation of a vaccine, and they say there was a 10 microgram dose before 12 years old and a 10 microgram dose after 12 years old, that will still count and it will still be considered the correct thing to do. So just quickly, any myths about, COVID vaccine? Yes, you can give vaccine to children with allergies. You can give them to kids with underlying medical illnesses. You can give them to kids with ADHD. You can give vaccines to any child who has anything except an allergy to a previous dose of the same vaccine, a reaction to a component of the vaccine, and specifically polyethylene glycol, which is what most parents know as Miralax. This is what's contained in the vaccine. It's cell-free, preservative-free, animal product-free. There's no synthetic messenger. There's synthetic messenger RNA that's modified. And then we have lipids, which we all eat lipids. And then all these other components, which are very common and you'll find in a lot of other food and drugs, including simple things like sodium, which is salt, and sucrose, which is sugar. Does it affect your fertility? No. So mRNA vaccines cannot get into your DNA. So the little purple dot in the middle of that cell is your nucleus, where your DNA is. But remember, I showed you that where mRNA enters the cell and makes spike protein is actually in that lighter gray part out in the cytoplasm here, where that machinery was. Your cells never allow mRNA into the nucleus. Even you make mRNA all the time, like you're making it right now, and that mRNA is never going to be able to cross that barrier there. and therefore the vaccine can't really cross that barrier either. And it's really very degradable. Your own cellular enzymes are going to break that down into little peptides and proteins, and you really don't need to worry about any of these quote long-term effects, because the vaccine doesn't even stay long enough than a few days after it stimulates your immune response. So this is a myth that mRNA vaccines are brand new technology. Actually, it's been 30 years in the making, and as you can see in this paper that was published prior to the pandemic in 2018 or 19, I believe, that there was actually already 30 decades of mRNA development. And I was able to listen to one of the developers of the mRNA platform, who was looking at different viruses, other viruses like Zika, Ebola, flu, HIV. They were looking at this mRNA platform for all of these other viruses prior to COVID. And the reasons we didn't use it were because it's expensive. You need to keep it in -70-degree freezers, which is not commonly found in doctors' offices. It's been basically funded, and not just funded, but actually researched to a point now where we feel confident because we've been able to put the resources. We've never had a pandemic before like this ever. And so now we had to put resources into technology that was already there, that we knew worked, but worked for much more rare and less common infections that we can now apply to a more common one. And so the mRNA vaccine doesn't have any virus components. It basically is like it's basically the mRNA that's triggering your own body to make that spike protein in your own cells so that your antibodies can then recognize it. So some FAQs for the adolescents, and I'm kind of harping on adolescents because we have been seeing lower rates of vaccine uptake in adolescents compared to adults. And for children right now, it's available. We have the same dose for 12 to 15-year-olds as adults, and lower dose for younger children, as I mentioned. Moderna is working on getting their data together, and they are basically slating to enroll more subjects, basically because they do want to assess myocarditis risk for their product. And we see that there's a that there's this big question of like, so if I have natural immunity, why should I get vaccine? And really, it's because there's two big things. We don't know if natural immunity can protect against future variants, and I'm going to go into these variants and how they occur. And then we also know that if there's previous immunity, that when you boost the response when re-exposure, that can actually be mitigated by vaccine. So you actually want to boost a natural immune response because that will protect you. And we do know that vaccine immunity basically is giving a better B cell response than natural immunity. There's actually data for that. And the most important thing, which I haven't mentioned there, is that it is very, very clear that unvaccinated individuals are more likely to get reinfected with COVID than vaccinated individuals. And that I actually have seen with my own heard with my own ears, or parents said, oh, I've had COVID 2 times. I've had it this time. It was terrible, blah, blah, blah. And so, and they were unvaccinated, and they finally decided to get vaccinated. So it's not just, the morbidity and the mortality. It's you're staying home from work, you're quarantining for 10 days, you're exposing the community, you're exposing your family. So many reasons why you should be getting vaccinated and getting your child vaccinated. And we talked a little bit about this before, about the myocarditis, that basically it's more risky to get myocarditis from COVID itself than patients like in general in the population who get myocarditis, because myocarditis existed before a COVID vaccine came out. We would see myocarditis due to other reasons, but it's definitely more common with COVID-19, and vaccine can prevent that. So here are some myths and facts that we kind of went through already, but for some time, I'm just gonna move past this one and just want to quickly talk to you about the variants. Basically, variants are viruses that are trying to survive and propagate. And you've heard about a lot of these variants in the news, the B.1.1.7 variant that came out last year, and then, of course, Delta variant that emerged this spring and this year. And, this is a nice little graphic to show you in the pictures of these, how frequently the actual variant is happening. And this was back, in 2020. And then you see over the year, basically how these variants changed. And then down here in the winter of 2020, 2021, that's when we started seeing this B117 come out. And it's very important to note that this is basically the virus trying to figure out how to infect people more efficiently than it already has. And that leads me to just talking a little bit about what is it that we're looking for here. So here, this is back last year in August to September. We were at really nice low rates of infection. And then suddenly you see this sudden increase in slope, showing that this variant decided to be basically have a higher incidence or more frequent infections in a population. And this is a great graphic from the CDC showing, again, how B117 variant kind of slowly increased in our region, because we saw it emerge in the UK and other parts of the world last year in the winter, but how you slowly saw it kind of emerge in the spring this year. And now this is all Delta variant, and this is all starting this summer. And this is why we saw kids get infected, because we had this new variant that had what we call a higher reproductive number. So for one kid who's infected with a Delta variant, there would be 7 to 8 other people who could get infected, versus the original variants, where only if one person was infected, only 2 or 3 people will get infected from that exposure. And so it overtook all the other variants. And you can see here, it continues to be the predominant variant in the population. And this is concerning because these variants of concern, there's always others that are going to be around the corner. And we know that the vaccine works against Delta variant. There's a lot of studies that have been showing that already. And because we know that, we're in a good place. Like, our numbers are sort of plateauing right now. And if we can get everyone vaccinated now before we get another mutation, before another variant comes around, before another wave comes around, we'll be in a much better place and hopefully get more to normal. And this is, again, a graphic kind of explaining how easily infected you can get with the original COVID strain versus the Delta variant, which you see here about 5 to 6 people versus only 2 or 3 people that can get infected if you have COVID and exposure to COVID or something COVID. Now to kids, this is basically a point that Dr. Fagan made over and over and over again, but this is a really great pictorial of how the hospitalizations have slowly increased over time. And this is overall for 0 to 17. And then you see the 12 to 17-year-olds, right? The 5 to 11-year-olds, it's significant. You see this group here? And look at that. No one really talks about the 0 to 40-year-olds, but there's a lot of babies who get COVID, in their first month of life, and we detect it because these kids babies with fever, we automatically want to see them in the hospital. That's what your pediatrician will do. And this is really important because those kids will never really be able, from 0 to 6 months old, get them vaccinated, because we're really only doing the studies in 6 months and older. So in order to protect these little babies, we also have to create as much immunity in our population. Another really great slide about B117 variant in the WHO put out this graphic of how common in the dark blue that we saw, B117 last year, and now the same blue is Delta variant. So you can see how this was, I pulled in October of this year, and you can see how it basically has taken over where all the other B117 variant or the UK variant was. And this is a great app that I use like a hawk, and I wanted to just demonstrate. I pulled this last year from the summer, and it was like the best percent we saw. I was just so excited. Oh my gosh, look how low is that case number. We were so excited last year, and that maybe I'm sorry, this is this year, 2021, that in the spring after Delta variant kind of started, before Delta variant came along, after B117 kind of made its exit, we had gone to such a low rate. Last summer too, it was like even better than this. And now this is where we were like around last in September, and we're like a little bit lower, like we're maybe at like 2-3% now, depending Nassau, Suffolk County. And, you know, it's just kind of plateaued. I mean, it's gotten better since the summer for sure, but it's not necessarily going away. And that's, I guess, the point that we want to make. And yes, people are still dying from COVID. This is a point that we need to make. People are still dying from COVID. There is still a pandemic. And these are the millions of people that have confirmed cases. And we see that look at this great number though, that we have so many billions of doses that have been given. And this is with vaccine, we're still seeing this much COVID. So basically for the future, like the variants are going to try to spread more quickly. They're trying to cause mild or severe disease, evade detection, increase susceptibility to medical therapies, decrease susceptibility to medical therapies, and then these monoclonal antibodies we use, or try to evade our natural or vaccine-induced immunity. So that's why we're trying to get on the ball and get your kids vaccinated now, as opposed to trying to wait for quote unquote more data when you have a double-blinded placebo-controlled trial with the best data you could possibly find for pediatric vaccines. I'm actually going to skip some of this stuff about the schools, but I think some parents have questions about why do we do all this stuff in the school? And it's basically the correlate of when you get high prevalence of COVID in the school is when the community has high prevalence. So if you have a lot of COVID in a community, you're going to have a lot of COVID in school. And you don't really see the schools driving the outbreaks. But we also have been seeing a large number of kids, 5 to 17 years old, who are positive, and these are school reported positives. So there might be even more than that, but this is what the school is reporting to us. And this is like Long Island, like has even, you know, a pretty significant number compared to New York City. And so we have to be cognizant that, you know, we still have kids who might be having COVID in the school and can still transmit. There's some really great mitigation that we use, right? That we had used social distancing, and we had tried to see, you know, if, and we used masking, and we tried cohorting, and we did all these strategies. And, you know, really, we still saw staff to staff transmission, which was higher definitely than students to staff, but staff to students definitely still occurred. And then this is all pre-vaccine data. Students to students were less likely, but we did see that in transmissions were higher in high school students, elementary school, because there's probably more social interaction outside of school and in school in that age group. And that, you know, when there's layering of strategies in place, that you can have less student to student transmission. But wouldn't it be great if we didn't have to have all these layered prevention strategies, because your classroom will be full of vaccinated children. And that's why we ask for vaccine proof when you enter school. And this is why it's a key take home point, that this mitigation with vaccine, with all these other things in place, until we can get our pandemic under control, is going to be our way out of this. Again, this is just, you know, children and adults, how when stuff goes up in adults, then the prevalence of COVID goes up in children. So it definitely mirrors one another. And this is really great graphic about how there's school transmission, you know, where you have these round ones are adults and these square ones are kids, from this study in Belgium where they were not using masks or physical distancing, and how COVID would spread from those adults so for example, there is some adult to adult transmission, like here to here, but you see here there is child transmission going on, child to adult transmission. So it does happen. And vaccination basically is our best way out of this. Okay, so music classes have been even trying to put in mitigation strategies. And there's this really great study that showed that how to basically still have music class with instruments and still be safe. So multi-inflammatory syndrome in children actually occurs after you've been infected with COVID. So you may be asymptomatic, like you don't even know you were infected with COVID, or mildly symptomatic. And then 4 to 6 weeks later, you get fever and you get inflammation, you get these organ systems, like your heart can be involved, your GI system can be involved. And, you know, we've seen, this is much higher actually now, this is an older statistic. Like 5,000 was maybe 2 months ago. It's probably closer to 7,000 now. And then we've had many more misty deaths, meeting this case definition. And total deaths from COVID, as was mentioned before, is over 700. And if you look at total deaths from COVID compared to, say, influenza, in 1 year, you would have maybe 100 to 150 pediatric deaths. And in like a year and a half, maybe what 2 years in March, but a year and a half, you have 700 deaths. I mean, that's literally almost like 2 to 3 times more deaths. And, we have influenza vaccine on board and still had that many deaths. Imagine, how much fewer deaths we'd see if we could get everyone COVID vaccinated. And there was a question about healthy children versus unhealthy children in the chat. And so 30% of children who have been hospitalized with COVID are healthy kids. And we actually saw that when we did our study at Cohen's with that first wave, that, about 25% of the kids that were 25% of the kids were healthy kids and they were all like, almost all of them were all adolescents as well. Again, speaking towards, what kind of exposures they may have had that may have been different than their younger kids. And this is just our last thing to touch on, like pandemics, epidemics, and endemic. Where are we going? So we're trying to get out of a pandemic, right? We're trying to get out of these global outbreaks of infection. And it would be nice to see just local outbreaks. Hopefully we wouldn't even see that much, because that basically means those are the local areas where we don't see as much vaccination rates. And then we get to endemic, where we have just this baseline rate of circulating disease, but you don't get these big outbreaks. And that's a possibility that we're looking at in the future, but we're hoping that if there's not a huge variant change or mutation change or a new wave, and we get enough people vaccinated, we can be in the place we are like for measles, where we don't see more than a few outbreaks every few years, instead of like every day. And we maybe get into the point where like we've almost eradicated polio. Respiratory viruses are indeed, much more contagious, but there are so many mitigations factors we can put in place, but vaccination is the most important. Here are some figure references, and these are my kids. I'm just going to end. I know we only have a few minutes, but on the fact that, I'm a parent, I'm a mom of these 2 boys. They actually were enrolled in the Pfizer and the Moderna trial. This one was Pfizer, the big one was Moderna. And we pulled our older one out of the Moderna trial because I wanted to get him vaccinated for Pfizer, and he was complaining about having to do the nose swabs all the time. And my little one actually, and he was placebo. That's why we decided to get him the Pfizer vaccine. But this one actually got Pfizer vaccine, had very minimal side effects, like nothing with the first dose really. I was almost doubting he got it. In the second dose, he had a little redness and swelling, chills, but he went to school the next day. My son just got vaccinated last week at Cohen's Children's, and has been doing fine. He complained a little bit of arm pain that day and did great. And so, I even know more than like the layperson about the risks of this and the risks of that, and oh my gosh, like what could happen. But hey, I wanted them to feel like they were empowered, and I wanted and they were very excited to be a part of these trials, because they knew that this data, this information is going to help other kids get vaccinated. So if there's any reason you're going to go out and make that appointment for your kid's vaccination, it's because my kids went through a bunch of blood draws and nasal swabs and extra shots, because this poor guy had to get 4 shots because he got placebo. He's going to get his 4th shot soon in Thanksgiving, around Thanksgiving. So your children can get vaccine and be protected. Thank you very much.
Thank you so much. We have practically ran out of time, but I am going to come and bring in some of the really excellent questions. Your wonderful information covered a lot of the questions, so thank you for that, but maybe we can just go through a couple. There was a question about actually getting the vaccine. Are numbing creams helpful? Can they be requested? Can Motrin be taken after? Dr. Fagan.
I can start that. Numbing creams can be helpful, but remember, numbing creams really are just anesthetizing the surface of the skin. the needle has, you know, there's a length to the needle, so it's going to go past that that barrier that's numb. So it can put it this way, it can lessen but not really eliminate. You know, that's something to discuss with, you know, your child's pediatrician who may be able to provide that. And you know, there are obviously risks for taking any medication. So, you know, my advice for my patients is, if you start to experience symptoms, then, you know, fine, go ahead, take some ibuprofen, take some acetaminophen, but I don't recommend taking it, you know, just immediately, you know, afterwards, for when chances are you're absolutely going to be fine.
Okay. Another practical, thank you so much. Another practical question is giving it together with the flu vaccine or other vaccines that are scheduled for kids. Is that recommended? Or if not, how long do we wait in between?
So the CDC has been very clear about this, as well as the New York State Department of Health. COVID vaccines can be administered with any other recommended vaccine. And in fact, in our Cohen Pediatric offices, where we will be running, you know, COVID vaccine, quote unquote, clinics, we will also be offering influenza vaccine at the same time. So there's no reason why a patient, child, an adult could not get COVID and another.
Great. And maybe one last question for Dr. King. The question was, the adult vaccines, the vaccine became less effective after 4 to 6 months. Is it expected that this will be the case for the pediatric vaccine, and will kids be needing annual vaccinations?
So I think it's too early to say anything about boosters. So right now, for adults, there's 2 reasons you would get a second dose. One is it's because it's a part of a series of doses you need because you're immunocompromised, so your B cells don't work as well as the rest of the population, or your T cells in that part of that immune response I showed you. And so you need a 3rd dose in the series. Or if you are someone who's a high risk person, so meaning someone who's going to be coming in contact with a lot of people, such as a healthcare worker, you would benefit from a boosted response, because your immune response will be much better to protect yourself. And especially if you have comorbidities or you're elderly. These are all because your immune system, when you are older or you have other medical problems, is not going to be as reliable without that 3rd dose. For kids, we're not really sure we're going to need that or not, because we have to look at the data from what happens to the waning immunity. It could be that, you know, some people say that if you're sort of, for the example, that you get an infection when you're a toddler, and you've seen that infection, your body's built an immune response, that could be a really great immune response for the rest of your life, and you may not necessarily need to ever get that infection again. But we're not sure if COVID is going to work like that, or COVID vaccine, for that matter, works like that. There are some vaccines, like measles vaccine, that no matter if you have the infection or the vaccine, you're not going to necessarily get that infection again. And so we have seen people get COVID again, despite you know, vaccination and despite natural immunity. So we'll have to still see what happens with kids.
Great. Thank you so much. There's many more questions, I'm sure, on everybody's mind, but I'm also trying to be mindful of everybody's time. So thank you so much for joining us today. Please also speak with your pediatrician if you have any further questions or specific questions about your child. We also had put in the chat the link to the Northwell site to schedule vaccinations. And we thank you so much for joining us. As mentioned earlier, the recording will be available on our YouTube channel. Thank you so much. Stay healthy and happy holidays.
Good night, everyone. Thank you.
Bye.